Good afternoon and welcome to the meeting of the Health Overview and Scrutiny Committee. I am the Deputy Chairman, Brenda Seaton. I'm chairing for the meeting today as Jonathan Morgan is on holiday. This meeting is being broadcast live to the public via the YouTube and will be available for viewing on YouTube after the meeting. Please turn your microphones on when you're speaking and turn it off when you have finished, please. There are two substitutes today. Mr. Allen is here for Mr. Hills and Mrs. Fryer is here for Mr. Morgan. I welcome to this meeting, as usual, the Cabinet Lead Member for Health, Mrs. Louise Richardson. Welcome. Item 1, minutes from the meeting held on the 13th of September, pages 5 to 24 on your agenda. I propose that these minutes of the meeting are taken as read and I will confirm and sign them. Thank you. Thank you. We have had no questions submitted by the public and there are no questions by members under the standing order of 7 and 7.3 and 7.5. We have received no questions from members. Thought I'd just read that out. Right, and there are no urgent items. Do any members have any interests to declare? Mr. Harrison.
On item vascular dementia, just to declare that my wife is very ill with it, so thank you.
Thank you. Anybody else have anything to declare?
Thank you, Chair. In a similar vein, I'll make a similar declaration as my mother is in residential care with vascular dementia and Alzheimer's. Thank you.
Thank you, Mr. Hills.
So just to clarify, you will both be remaining in the room for that item. Okay, that's fine. Thank you.
On the item? Yes. And are there any declarations of party whip? I've not been advised of any, so there are none to this one. And I have received no petitions. So the first item on your agenda is the Winter Plan 23-24, and this is on page 25 to 76 of your agenda. This report is going to be presented by John Melbourne, Chief Operating Officer for University Hospitals of Leicester, NHS Trust, and Kay Darby, Deputy Director, Vaccination Programme. There is also John Wilson, Director of Adults and Communities, is joining us online in case there are any questions about discharges and adult social care. Welcome.
Thank you for having us today. Just to reiterate, I'm John Melbourne. I'm the Chief Operating Officer at University Hospitals of Leicester, to my right.
Afternoon, Rachel Navias. I'm the Chief Operating Officer for the Leicester Rutland Integrated Care Board.
Good afternoon, I'm Kay Darby, Deputy Director with the ICB and Lead for Vaccination Programme.
Thank you.
Thank you.
Right, if you'd like to
Thank you.
walk us through this, please. Thank you.
Of course. So what we've presented here is a summary of our plans for this winter. It is an important point that we want to move away from just planning for winter. We're moving to much longer term planning. And so much of our plan we commissioned at the start of this year, March, April time, to make sure that we have long-term plans in place to see improvements across all of our pathways, including in urgent and emergency care. The other point linked to this is urgent and emergency care is a key part of winter. We want to make sure people have access to services, but so is our elective care and our planned care. We want to make sure that we keep as much planned care going as possible through the winter months. And so they are absolutely symbiotic in our planning within here, which we'll come on to in a moment. So I'm going to start with the summary of what we are doing this winter. There was a national plan for recovering urgent and emergency care services published in January of this year. And that focused on 4 areas which are covered at the start of this paper. One is around workforce and making sure that we have the right workforce for our services. I've just My computer has just shut down on me, so I can get it straight back. Secondly is around increasing capacity and making sure that we have the right capacity across our services. Thirdly is around making sure that we have treatment for people in the right place, which is a really fundamental point for Leicestershire. We want people to get to the right place for their care as swiftly as possible. And finally, it's about increasing that integration between our health and social care services. And that feeds through all of our planning here. What you see within this paper is a detailed plan that summarises within each of those areas what we're doing about the winter ahead. What I'd like to do is pull out some of those areas that I think will be of particular interest for the months to come. We talk regularly in our services about flow into our hospitals, flow through our hospitals, and flow out into our communities. It's fundamental within that we work in partnership across health and social care, and we have very close links with primary care, with us as an acute trust, with Leicestershire Partnership Trust, with the ICB, with social care, and many others, including private sector and independent sector providers in creating this plan. Some of the things that we are doing this winter include a significant increase in our virtual ward capacity, and that's both for us as a trust, but also partners such as Leicester Partnership Trust. This means that if people don't need to be in a hospital bed, but need some form of remote monitoring or care that they can receive virtually, we've significantly increased both our utilisation of that capacity, but also our bed numbers available virtually this winter. We are also working very closely to put respiratory support into the community. That means people don't need to come to hospital if they have some respiratory distress. In terms of flow through our system, we're doing a lot. So we are putting in increased capacity this week. Leicestershire Partnership Trust opened up some additional bedded capacity. We at the Glenfield Hospital down the road are opening an acute respiratory unit, which is basically increased monitoring for respiratory conditions over this winter. And in early next year, there'll be an additional ward opened at the Glenfield Hospital. We're also increasing our access to same-day emergency care services. So this week we open up a new unit at the Glenfield, which is the Glenfield Chest Pain Centre, or GCPC, as I very difficultly keep on saying. And we're also expanding our same-day emergency care services at the Leicester Royal Infirmary as well, which means that people can come, get their treatment and go home on the same day, rather than having to stay in overnight, which they previously would have done. Finally, we're really trying to improve our discharge processes to make sure we have the right, we get people out of hospital as soon as they don't need to be in. Again, a fundamental part of what our plans are is getting people to the right place for their care. We know we have at any one time in our hospitals too many people in there that don't need to be in there. There are lots of challenges around that, and we're working very closely with social care colleagues, with primary care, Leicestershire Partnership Trust, to make sure that we get people to the right place for their care, or indeed home without additional care as soon as possible. We're discharging a lot more patients this year than we were at this stage last year. However, we also have some delays which we need to do more to address, and I know that John and others are working incredibly hard to reduce the level of delays across our system to get people home as swiftly, or to their onward place of care, as swiftly as possible. So they're the headlines of what we're doing. I'm very happy to go into more detail of any of our plans within here. What I do think is important to set this in, though, is the context of our improvement over the last 12 months. In 2022, we were regularly holding ambulances outside of our hospitals. We were one of the most challenged in the country. Across the course of 2023. We have significantly improved that position, with an over 80% decrease in our hours lost to ambulance handovers outside of the Leicester Royal Infirmary. And again, that's thank you to the help of all partners in achieving that progress. Alongside this, we have seen significant reductions in our waiting list, both our longer waiters and our total waiting list. So after years of our waiting list going the wrong way due to many reasons, we're seeing progress in both our urgent and emergency care and our planned care services. And we believe that this plan will further back up that progress and allow me to be sat here at this stage next year to be saying we've significantly increased our waiting list further, which I am confident about. So again, we are seeing that progress. That said, it is going to be a difficult winter. We've seen over the last couple of weeks a significant increase in the acuity and the pressures we're facing on our urgent emergency care pathways, which are playing out across the system. And we know it is going to be difficult. So do I think this plan we have today is good? I do. Do I think it is? Do we need to do more? Yes, absolutely we do. And we're working every day to do more, because we know how challenging a winter will be for both us in Leicestershire, but also across the country.
Thank you, Chair. If I may just draw out 2 additional points to what my colleague John has said. There is a significant increase in both the 111 and the 999 call handling workforce that we've put into place across, particularly across the East Midlands, but focused on the Leicestershire desk as well, to make sure that not only can people access the care on the phone, but they are then directed and booked an appointment, so they're not waiting in specific places like the emergency department unnecessarily. So those straight to access pathways have proved very popular with our patients, particularly because they're with booked appointments, as opposed to go and sit and wait in a waiting room. We will look to expand those through the course of winter as well. We've got some additional capacity coming into primary care, where we can again book into using that 111 service, which will only augment everything that John's just said from an inflow perspective. From an outflow perspective, in terms of making sure that our patients are in the right place at the right time, our focus has been, of course, on reablement, working very closely with John Wilson and team on making sure we're using those resources appropriately and not using, as we had seen in previous winters, increases in things like residential care. People are going home when they need to go home, and they're going into care when they need to go into care, and we continue to work in partnership to get that right for our patients.
No, not unless there's any specific questions on. I can give you an update on COVID and flu uptake rates. If that's useful, I've just noticed that they weren't included in the pack and they move constantly. So what we're currently seeing in relation to COVID vaccination rates, we've got a 43% uptake overall, with 49% in Rutland, 48.6% in county, and the campaign continues to the 18th of December technically, with a strong inequalities plan attached to that to drive that uptake. In relation to flu, it has gone slightly up since the pack was produced on 18th of October, and the figures yesterday were at 39%. So we're seeing just shy of 51% uptake in Rutland and just shy of 55% uptake in county, and that campaign continues to the end of March.
Thank you very much, Madam Chairman. Welcome to our meeting this afternoon. This is interesting. There's a lot of bits of information in here. Tackling the variation in performance is really a challenge. I get all of that and I understand that. When I read the document, it's full of ambitions. I wish there was more determination. This is our goal, so we all know ambition is a hope. But so there's a little bit of worry in that respect. The thought of discharging people is really, really critical to the whole show. That's what really this is all about, because you've only got so many beds, so how do you go about it? I think your virtual bed programme's very good, but I'm not quite certain how many virtual beds you'll be running. Is it a dozen or so, or is it going to be 100? I'm trying to understand, because the language is good, but how exciting is it looking at the overall picture? So that's the first thought. Second thought is that, you know, to get people out, you're going to have to work with social services. And I just wonder what sort of in-depth involvement you've had with our director here, John, who's first class director of that department, and has got great achievements in it for our county position in that. Because without that, where are you going to get all of these beds? And the other thing is, when you talk about recruiting staff, oh, great, you need more staff. I understand that. But I just don't see the pathways. How are you going to do this? And have you got plans? And how many people are on board and everything else? So there's a few points there, but really concerned about the community aspect, because clearly you're going to need help. It's not what you're going to manage. So you've got to work with neighbouring bodies, associates, the area health authority being the most obvious one, to be able to probably work with you in conjunction. How did that discussion go, and what assurances have you had from the county on what they can do to support your ambition, as you put it? Thank you.
Thank you for that. Can I bring John Wilson in at this point, please? Thank you, John.
Yeah, thank you, Chair. So just in response to those comments, we do work, and as John and Rachna have pointed out, we do work very closely together in terms of our response to the demands on the whole system, health and care system. Now, obviously, a number of the demands that we see in social care do derive from hospital and from hospital discharge. And indeed, that is the one area where we've seen over the last 2 years significant increases, not so much in the numbers of people being discharged, but in the care requirements. So the proportion of people being discharged from hospital who require social care and the amount of social care that people need has increased. Now, maybe many reasons for that. Around sort of, the nature of the need of people waiting for hospital admission, post-COVID, post-pandemic, etc., etc. Lots of reasons for that. And we're not the only place in the country that's seeing that. That's a national picture. But we have worked very closely together to address that as far as we can. As it says in the report, we've received an amount of additional funding from government to meet some of those challenges, but equally NHS colleagues have agreed with us to fund additional capacity within social care, both in hospital. So we've got additional staff on wards, working with ward staff to assess people for discharge, and equally in the community, we've put additional capacity in to review people in who are receiving home care and temporary bedded care, so that we can keep that flow, so we can keep people coming out of hospital, keep the flow that John was talking about. We're also working closely together to develop a new intake service. So by that, what I mean is that we're trying to develop a service based on our internal reablement team to meet the needs of everybody being discharged from hospital, so that everybody who comes out of hospital who has a social care need will initially go through our reablement service before any other service, so that we can have a proper assessment over a few days whilst the person's at home, make sure that everybody's got the right optimal care before we then perhaps commission further care down the line. That's something that we're working towards, and we're hoping to have that in place over this winter. It's worth pointing out that service has seen increased demand. So we've gone from having 70 people starting that service a week to 100 people starting that service a week over the last couple of months. So there are significant pressures there. And of course, we also, as members will be aware, have significant financial pressures within the adult social care department and across the council due to the increased demand. And that is also something that we need to kind of closely watch and manage together.
Yes, thank you. I agree with those points. I've written down your points, so I'll make sure I address them all. So I'll start with the social care partnership, if I may. So I agree with John. We've got really good relationships. We talk regularly across the system. It is challenging, though. There's no getting away from that. We have people in our beds that are awaiting packages of care, and we're working closely to try and minimise delays across that. But also, I recognise the financial pressures that local authorities are under. And so what we're trying to do is balance that across the system. And John is right. We are seeing, if we had a clinician here, they would say they're seeing increasing acuity of patients. And nationally, since COVID, we've seen an increased length of stay on our urgent and emergency care pathways. And I think you see that playing through with some of the challenges we're facing. So we're doing a lot of work, and that fits into we need to do more, because we do have delays, not just with social care, but across the board. Picking up some of the other points, thank you for the comments on the writing of it. Behind this, we have detailed plans with names against it, and names and timescales and numbers against all of our interventions. And so absolutely, we have the specificity of plans. And most importantly, I think we have evidence of improvement across our planned and urgent emergency care pathways that can show what we said we will do, we will deliver, and it will lead to better outcomes for patients. Virtual wards, I don't have the exact numbers with me, but we have around 100 beds open at the moment, and we hope to at least double that in the coming months. And finally, workforce. We are becoming increasingly successful with recruitment. We're ahead of our plan for recruitment for this year, and our vacancy rate is going down. Of course, with that comes a financial challenge that we're all facing as well. But actually, recruitment is going really well. And I hope that is because we're showing increasing trust in patients, increasing optimism about where we're going as a trust. And I think that is mirrored across the system.
Mr. Charlesworth, please.
Thank you, Chair. It's just, my question was going to be on that point as well about staff. You say it's improved over the past 12 months, number of staff you've got, but do you have the resources to have a complete set of staff, budget-wise?
That's a very good question. Every organisation in the country will have a vacancy rate at any one time because of the fact, you've got some people leaving, some people joining the organisation. And so it would be a challenge for us financially if we had no vacancy rate at all, but equally we would have other metrics that would go up. For example, we do a lot more activity because we would have lower vacancy rates. So I can't simply say to you whether we can or can't afford it, I'm afraid. But it would present a challenge in one area, but it presents a big bonus in another area. What I would say is we're very clear, and our Chief Finance Officer is very clear. We will try every day to recruit to our establishment because that's the right things to do for patient safety and otherwise.
Because I think the vacancy rate in the NHS in general is well over 10%, isn't it? Something like 112,000 vacant positions. And of course, without the staff, nothing else sort of follows on in improvement terms. So you get the staff in place, then it's a good plan. I like it. And we've seen progress here over the past 12 months in waiting lists. So praise where praise is due, and keep up the good work.
Thank you. And just picking up that point, what we want to do is recruit substantive people into our workforce that can be with us for the long term, so we can reduce our reliance on agency staffing, which is less good value. And of course, they're with us for the short term.
Councillor Mr. Pendleton.
Thank you, Madam Chair. Thank you for a super glowing ambition. And you'll gather that I've said that, and I'm now going to ask you actually to, in future, consider whether you could underpin this glowing ambition. Forgive me, but we could write this every year, and it's awful to say that, because it's the same priorities that we're grinding away at, and you're doing extremely well. Don't get me wrong. I think you do yourself down a little bit in that you don't put the figures in. You said that this report was underpinned with your goals and figures, which and names. Don't want that. That's okay. But would love to try to be able, as a scrutiny member, to chart the improvement that because you will have done it, and I think you'll get around a lot of skepticism if you could next time consider bringing the facts as well. And it's not totally without facts, this report, but the trajectories and the percentages will be very helpful. Just a comment. Thanks.
I may Okay, thank you. It's a very fair comment. Thank you. What we've tried to do, and I accept this is probably my mentality of what next? How do we improve further? What do we do next? I think, and that's what we tried to come with our winter plan for this year. I take it on board, and next time we come here, we will come with evidence of what we are delivering to give you that proof alongside it.
Mr. Mayor.
Cheers. Thank you, Chair. Thank you very much for your responses. And I just wanted to talk about one aspect of your report, which is expanding services in the community. Where you said, and this was in July when you wrote this report or over the summer, that you'd like to expand and do all these provisions. We're now in November. How has that gone? Have you been able to implement some of this? Are we able to divert some of this community emergency admissions to the community hospitals or settings? Is that something that you've been able to start on? Thank you.
Thank you. So you're absolutely right. We wrote this back in July, and this is, as John says, we had put this plan in place in March, actually. So we had some good solid plans in terms of actual evidence of delivery. So we have had a significant increase in the numbers of people who are being now treated in the community. You will have heard, I think I came here a couple of months ago and I talked to you about the unscheduled care hub. We are now taking something like, we've taken 4,000 people off the ambulance stack who traditionally would have waited for an ambulance, potentially gone into the Leicester Royal Infirmary, had a 2-week length of stay and then been discharged. The service that we've put into place in partnership with our local authority colleagues across Leicestershire, as well as our DHU colleagues, Derbyshire Health United, who provide our 111 services. What they're doing is they're taking people off the ambulance stack, they're assessing them, they're giving a holistic advice on what needs to be done, and they're treating the patient mainly in their own home, actually. So those patients aren't actually having to go anywhere, but they're being seen and treated in their own home. Now, those 4,000 people who may have gone back into those trusts would have been an additional demand that we are managing to stop. All of the quality improvement metrics that we've got from a patient experience perspective and a staff experience perspective are telling us that this is absolutely the right thing to do. People want to be seen in their place of residence and only being taken into the acute trust when they absolutely need to be, and that's the right thing to do. So we've wrapped services around. John talked earlier about some of that demand that we're creating because of this, because we're doing the right thing. So some of this is about balancing, making sure that we can do what we said that we would do. Some of it is keeping an eye on the finances and making sure that we've got then sustainable finances to put some of this in place. The other thing that's referenced in the report is the urgent community response service. So it says that we aim to get 80% of people seen within 2 hours. We are currently at 94%, and that has just steadily grown through the course of the year. And again, that is a joint partnership between my Leicestershire Partnership Trust colleagues and my local government colleagues. So real partnership working, evidence-based, and we can really show the metrics. So we're happy to bring those next time.
Thank you, Chair. My name's Kate Revel. I'm a Head of Service in Adults and Communities Department for Leicestershire County Council. My role includes the commissioning and quality of adult social care services. So I'm reporting to you bringing a report on behalf of the Directors of Adults and Communities and Public Health. So it's a joint report, excuse me, and it's relating to the outcome of consultation on the LLR Joint Living Well with Dementia strategy, which will run for a 5-year period between 24 and 28 if approved. So the committee is invited to make comments before the request for final approval of the strategy to Cabinet on the 24th of November, so in a few weeks' time. Adults and Communities Overview and Scrutiny Committee considered a report on the strategy in June this year, and that was when the strategy was in its draft form and pre-consultation. Members gave a range of really useful comments, including recommendations that accommodation for people living with dementia should be included in the strategy, and that's been incorporated, and that further focus be given to disparity in diagnosis rates between the city and county. And again, that has been picked up through the place-based strategy delivery plans. On the 23rd of June, the Cabinet approved a formal 10-week consultation exercise on the draft strategy, and that has now concluded, and the results of that consultation exercise are included within your pack. The strategy is underpinned by the guiding principles from the NHS Well Pathway for Dementia, and it's been developed by a group which incorporates the 3 upper-tier local authorities, the City, County and Rutland, the ICB, and a range of voluntary sector organisations, including being informed by people who have lived experience of dementia. The current strategy, which is in place, has had a range of achievements which are listed in paragraph 9 of your report. The strong partnership approach continues. Dementia risk factors have been picked up as part of primary healthcare checks. Primary care practices are using a tool to assist them to develop dementia-friendly GP practices. There's been a specific dementia strategy, a specific chapter on dementia within the Joint Strategic Needs Assessment, information and advice provision, incorporation of the lived experience of people within the development of the new strategy, and folks with lived experience have seats on the Dementia Programme Board. In terms of areas of activity during the current strategy period that have proven challenging, include diagnosis rates. They have reduced substantially as a result of services being paused during the pandemic, and as a result within the county areas, the diagnosis rates are significantly lower than the national target and also the Leicester City rate. We think that's as a result of the diagnosis clinics being run exclusively at Glenfield Hospital, and within the new strategy there are actions which will see diagnosis clinics being run also in county locations, which we hope will address that. Admissions avoidance, admissions and discharge pathways and post-discharge support for people with complex dementia are a priority, and that in fact goes back to the previous item around winter plans and how we ensure that people with dementia can exit hospital when they're ready to and they have the appropriate support. And also activity that supports people to remain independent, something that's on everybody's agenda. So just looking then to the revised strategy, the partners have promoted the draft strategy widely. We wanted to ensure that we got a range of feedback, and that wasn't all through online means. One of the strong recommendations from members when we came to formal meetings in June was that there should be a range of opportunities for people to contribute to the consultation. Of course, online means were also there, but printed versions were available. There was a dedicated number that people could ring to give their feedback on the consultation. We had the opportunity to go out to speak to specific groups to describe the contents of the strategy and seek their feedback. So there was direct engagement with community groups, Jamila's Legacy, Age UK, Alzheimer's Society and the Carers Centre, and we also had a couple of briefings to the Leicestershire Equalities Challenge Group, who were consulted as part of the consultation. Across the patch, LLR-wide, there were 319 unique responses, of which just over 200 were specific to Leicestershire, and your consultation summary within your pack focuses entirely on the Leicestershire responses so that you can be clear that you're looking at the responses from the people of Leicestershire. So overall, responses to the consultation indicated that there's broad agreement with its aims and that the actions listed in the strategy are beneficial, but there were concerns raised relating to two particular areas, including whether people think that health and social care services that support people living with dementia work well together, and whether staff are confident and competent to support people with dementia. So those areas are being picked up as part of the strategy and the individual organisations' action plans. Some of the key themes that have emerged include the ceasing of the Admiral nurse provision in the county. That ended earlier in 2023, and that leaves a gap which has been picked up. And a feeling that the memory assessment service should refer all people to the dementia support service on diagnosis. More support's required to fill the gaps between people being diagnosed and developing eligible adult social care needs, and issues around training of staff working with people living with dementia. So just moving on then, a report will be presented to the Cabinet on the 24th of November to seek approval of the draft strategy and the County Council's action plan. So in conclusion, the Dementia Programme Board will monitor the progress of the action plans and will support organisations to set targets for the year. A refreshed delivery group has commenced. There's been significant interest in the consultation from a wide range of stakeholders, and we were very pleased with the number of responses that we got, not only in terms of absolute numbers, but the range of different interest that was generated from individuals, people living with dementia, carers, community groups, and so on. So we think it has been a really robust exercise. And the recommendation is that the committee comments on the draft strategy and the consultation findings prior to the presentation of the outcome of the consultation and request for approval of the final strategy to the Cabinet later on this month.
Thank you very much for that presentation. And my question would have been about Admiral nurses. I know pre-COVID there was quite a strong launch and march forward with Admiral nurses, and I think they were well liked in the community because it not only helped the patient, it was the families surrounding it. So it was a rapport over care. So I was surprised to see its demise. Is that countrywide? Is it just sort of gone now, or is that just Leicestershire?
I understand that it's been a local decision. It isn't a service that's funded by the County Council. It has been health commissioners that have unfortunately had to make that decision, but it is something that we're working with them on in terms of understanding the benefit from the service. And I think the response to the consultation has shown that it is widely valued and missed.
Thank you for that. Mrs. Radford, is there anything you'd like to add?
No, not at the moment. I'm just here to listen to what everybody's got to say because I think it's a very good strategy that we've got. And it's just really, I've come along to listen to see what fellow councillors want to comment on. Thank you.
Thank you. Mr. Harrison, please.
Thank you, Madam Chairman. It's to do with the Admiral nurses. I've had first-hand experience with regard to my wife's care, and they are really significant because they're not dealing with a patient as such, they're dealing with the family, people closely involved in the care, trying to confront this situation, and their experience, knowledge and understanding is just so absolutely powerful and obvious. As holding hand and a bit of comfort to understand things is totally invaluable for my experience. So I've experienced it firsthand and spoke to others, and it's going to be very, very significant But I can only imagine people being put in those positions and think, well, what do I do? Because the doctors will only tell you, well, that's that. And, you know, who's there to tell you how the process, what happens, how you feel, how you'll feel later and everything else. It is an emotional package, and I wouldn't even be able to think of a value. If just as one individual can speak so highly, other people don't have the opportunity, but I'm sure their skills and ability has been outstanding. And I just think that is really tragic and sad, because people coming along as dementia begins to develop and as a potential terrible illness and inflicted on people, that, you know, people will, it's so handy to have somebody who can talk in such knowledge and detail. That's all I can say. But it'll be sadly missed. So if there's any ideas or thoughts you've got where a bit of funding here, there and everywhere could go towards a reinstatement, it would be amazingly good. Thank you.
Would you like to come back on that one?
I think we'll continue to work with health partners who are within the Dementia Partnership Board to share the experience of people who have first-hand use of the Admiral nursing service. The sort of feedback that you've given there is comparable to the sorts of feedback that others have given. It's very well regarded, invaluable, and we'll seek to work with health partners to hopefully at some point in the future and hopefully in the not too distant future reinstate the service. As I understand it, it is something that health commissioners would need to decide to reinstate. I don't believe that the council has the ability or powers to invest in that service, so it would need to be a partnership working with health commissioners around that. Thank you.
Thank you, Kate. Could I just ask now, Mrs. Burrows from Community Health Watch? Thank you.
Thank you, Chair. I just wanted to add in there, because we did a lot of work, Health Watch LLR, and it's in Kate's report, which is fantastic. And on the issue around Admiral nurses, we got a lot of individual testimonials from people who valued the service. We have written to the chair of the ICB about it. We have received a response. We are going to keep going on to the ICB with some of the concerns that we're getting from people, because that was one of the biggest things that came out of our research, was the loss of that service. So our chair is working closely to see what can be done, and as Kate rightly says, it will be health partners' decisions, but that was one of the biggest things that came out from all the people we spoke to who received Admiral nursing care, and it's a big loss at the minute for last year, but obviously there is still a service within the hospitals that we're aware of, so we're just trying to see how that might come across. So Health Watch is still keeping an eye on that bit, and I know we've got a member of our Health Watch team from Rutland who sit on the board as well.
Thank you for that, Mr. Allen.
Thank you very much, Chair. Just referring to page 87 in the report, which is section 4, the national picture. One of the sort of start figures quoted there is that 2/3 of people with dementia are women, and that currently there's around 600,000 people or women in the UK that are now living with dementia. Given that there's obviously a preponderance on women, has that been sort of factored into asking moving forwards, and are we addressing that locally? Thank you.
Yes, please, Kate. Thank you.
Yeah, I mean, that's it. That is interesting, isn't it? And I don't know whether it relates to perhaps women are more able to come forward and put themselves forward for a diagnosis. Perhaps there's other things going on. I personally don't know the reasons behind that. I can only assume, but that's the sort of thing that we will be looking at as part of the delivery plans to ensure not only are equality considerations addressed throughout the strategy period, but well, this is an equality issue, isn't it? If a certain proportion of the population are more likely to be diagnosed with dementia than the other, then that is an equality consideration that needs to be addressed through the approach to diagnosis, communication, advice, information, etc. Yeah, it's a really good point.
Thank you. Would you like to come in?
Yeah, thanks, Chair. I think the other one for me, Kate, is age-related. I'm trying hard to find a polite way of putting it, but I can't, which is, age is related to dementia and women live longer than men. So
there is something for me about, in terms of prevention of vascular dementia and the impact of physical activity, making certain, for instance, that women have as much opportunity to do physical activity and try and stave off something that comes along in relation to the strategy as well. So, yeah, not an easy one. There we go.
Thank you, Mike. Mr. Charlesworth.
Thank you, Chair. Yeah, it's just on getting people to the diagnosis stage. You know, I understand the reticence of people to come forward if they think they've got a problem like this, because they don't want that diagnosis, and I get that. But there seems, you talk about how when the diagnosis is made, you're improving things and the referrals and everything, and especially the underrepresented groups of the South Asian community. But what sort of communication system are you going to have to get people to come forward? Because that seems to be the stumbling block in people getting to the diagnosis stage, which understandably, as I've said, some people don't want to do. So how do you deal with that?
Thank you.
I think there's a range of different things that we have to do. It's about advice and information, about encouraging people to come forward for diagnosis at an appropriate stage. I think that we need to work with voluntary groups, carers organisations, GPs, all to encourage, I suppose, a number of different measures to ensure that people come forward and that they have access to diagnosis at a time, and I think critically for the county place that suits them, because as we've seen during the COVID period, diagnosis rates have dipped significantly within the county area when compared to the national position and also the position for the city. So there's something about where people are diagnosed as well.
Mrs. Richardson.
Do you think, yes, do you think that some of it is that people don't recognise it early enough? We don't know the specific things to be watching out for, and whether, you know, more information in that side of things so that people will actually think, oh, should I go and get that checked, rather than just think, well, it's only a little thing at the moment, I'll wait till later. Because the earlier we can pick people up, the longer we can keep them in a better state. So, you know, I think a lot, you know, going on your point, I think, you know, perhaps we should be looking at that end of the coin as well, and not just when they get to diagnosis. Thank you.
Thank you, Mrs. Fryer.
Thank you. I think another point through you, Chair, to do with getting people to recognise there's a problem. There's an awful lot more people, and quite often they are women, living alone. I know in my own street even that there are probably, out of 50 houses, there are probably 10 women living alone, and they often are not near family, and they are presumed to be coping well and are doing everything, and the shopping seems to be done and everything. Whereas there is a gentleman nearby who does have dementia, and his family and friends have sort of rushed in. Well, the ones that I'm talking about, and they are mainly women, are living alone. In my own family, there are 8 of us living alone and not near other members of family. And I think this is, and how do you get them involved? I know you can rely on friends to say, are you all right, and things, but again, it's pride that they don't want to go and admit they can't cope. So it's a very, very tricky situation how you get it, and it is almost back to the community. I mean, you can put out as many adverts, as many bits of paper, but it's getting local community involved. And also taking away the stigma. There is still a stigma of people admitting, oh, my memory's fading or it's old age. But dementia and Alzheimer's seems to still have a social stigma with it. And I think that's a hard barrier to knock down. But a very good report, very interesting. Thank you.
Thank you. Just thinking about the 2 adverts that are on at the moment about dementia. They do show couples. They don't show a lone person having to deal with this on their own. They are couples. They have got a relationship and somebody to care for them. And so probably we need to concentrate a bit on that more, that people are alone. And we've got a fantastic group in Thurmaston drummers, and for Alzheimer's, but they won't go unless they've got a partner to take them. And of course, the local councils, because of data protection, and why should we? We don't necessarily know who those people are, as we could reach out and encourage them to come along to a community building that is especially has got something on that's specially designed for people with dementia. Mr.
Cheers, thank you, Chair. I think this strategy is quite good actually, because dementia is actually a newer thing that we've identified as a health thing that's coming on. But I think it's right. People who have it may not know that they have it, if you get what I mean, especially if they live in their own. I want to, tag on to what Mrs. Fry is saying. But what are we doing to target family members to say, actually, look out, are you aware that somebody in your household may be suffering this? And they don't necessarily have to be elderly. Some people who suffer it are not that old. So I'd like to see what we would do differently going forward in this strategy that we tried before and thought actually it's not hitting the right target, so it's not hitting the BAME community, because we know there's a gap, and we've identified that gap. So how do we then reach out to those people? Or it may be that it's in a different community, but it's not hitting the right target because we're not identifying all those lovely little old ladies who are living alone, who potentially might be suffering dementia, but we're not reaching them for whatever reason. And it's important because obviously they need the support and the help regarding it, so they don't, potentially have an accident or worse. So that would be nice to see to identify that, yes, there's a gap, and we've identified the gap, but what we're going to do differently that we've tried before, I should say. Cheers.
Thanks, Kate.
Each organisation that's party to the Dementia Partnership Board and has participated in the development of the strategy has their own action plan, which the board will hold them to account on. What each organisation has done, including the County Council, is to look at the actions which were within the current strategy, progress towards those, what measures work particularly well and which we need to take further action on. They've been carried over into the new proposed strategy, has been further developed around those areas that we know we need to focus more attention on. There's been a substantial piece of work done by the City Council on behalf of the LLR partnership, but also by us, which we've fed into, and we've done our own equality impact assessment to identify those differential impacts on protected characteristics, so that we can really focus in on where our actions not reaching, where have they potential, where do we need to focus more efforts on. That's been part of the reason for the mechanisms that we've adopted for the consultation, to offer the opportunity to and approaching community groups to say, can we come out and speak to you about it? Not only about the strategy itself, which is, it's high level. What we really need also to do, and what we have done through the strategy, is talked about some of the actions that underpin the strategy, and it's the sorts of things that you've identified. Where do we need to focus specific effort on? Not only in the identification of people with dementia, supporting them to have a diagnosis, to receive the support that they need, and then all of the follow-on actions that come after that for social care and for health.
Thank you very much, Chair. Just picking up on the points Mrs. Fry and Mr. Mayer made. So, having an interest in it, I have seen some research recently that suggests that both social isolation and lack of mental stimulation can be both tributary factors to the onset and the speed of development of dementia. And from personal experience, quite often the person who's the sufferer is actually unaware that they've got a problem. It's the family and neighbours that are the first to realise there's something wrong. And when it's brought to light, it can quite often be the case that the sufferer is actually quite resistant to sort of following it up and getting any kind of a diagnosis, which can prove some challenges, I imagine. Thank you.
Mrs. Radford.
Yeah, I'm glad I came along to listen to all the comments. I mean, I did pick up about the Admiral nurses, and I think Mr. Charlesworth has said it right, that you may think you've got it, but there's no way are you going to go along to have a diagnosis because it's something that you're frightened to death of being told that you've got. And I don't know how we would overcome that concern, because I'm not sure whether or not, if you're diagnosed early enough, whether or not there's any medicines or stuff available to slow it down. So I think that, you know, we need to put people's minds at rest as well. If you are diagnosed with it, that there is help out there. And I think if I thought I'd got it out, I think you'd have to drag me along to go and find out, even if the people would like to take me. Do you know what I mean? I think it's something that is really, you know, concerning. And like Mrs. Fryer said, if you live on your own, your family might think you're coping all right, but you're not. You might have burnt the dinner or have to throw stuff away, but they don't know anything about it. So it is, I think, a really, really frightening thing to think about, that you might get it or a family member might get it. But I'm glad I came along and I've listened. So when it goes to Cabinet, if any of the Cabinet got any questions, hopefully I might have some of the answers, because we've spoken about it, discussed it today. Thank you very much.
Thank you. Well, hopefully we've made sufficient comments that could be taken on board, and particularly about the people that are alone and how we are going to reach those in the future, and probably try to think about how we can include the community in this. I mean, we all did rally round at the stage of COVID, and we all rallied round then with help. So probably something could be devised or put into motion that could involve the whole community. And anyway, this is going to Cabinet on the 24th of November. And I think, judging by the comments, we are quite happy to recommend that it would be approved by the Cabinet. Thank you very much.
Thank you, Chair, and thank you, the committee.
Moving on to the intermediate minor oral surgery. This item is on the agenda because the local dental committee raised concerns with the Cabinet lead member for health, Mrs. Richardson, about the discontinuation recommissioning process for intermediate minor oral surgery. Oh, it's very difficult to get my teeth around all of those big words in Leicester process. So the minor oral surgery in Leicestershire. In your agenda pack, there is a report from the local dental committee, and in response, there is also a report from the Integrated Care Board. At the meeting today, we have Dr. Hanif Moti from the local dental committee and Ket Chumunsa. I guess I pronounced that wrong, but apologies. Deputy Chief Strategy and Planning Officer, Integrated Care Board. Also Diane Wells, Senior Commission Manager, Pharmacy, Optomy and Dental, Liz Gundle, Deputy Head of Primary Care of East Midlands. I will let Hanif start the summarising in his report. Thank you and welcome.
Thank you, Chair. My name is Hanif Moti. I'm a general dental practitioner in Leicester. I've been here for over 33 years in Leicester. And I'm the chair of the local dental committee.
Please, Hanif. Yes.
I'm the chair of the local dental committee in Leicestershire. We represent all the dentists in Leicestershire, Leicester and Rutland, basically. This is Sarah, who's my colleague who sits also on the LDC. Do you want to introduce yourself, Sarah?
Hello, my name's Sarah May. Sorry, I've got a loud voice anyway. My name's Sarah May. I'm a member of Leicestershire Dental Committee. I'm a retired general dental practitioner, and I'm also the chair of the East Midland group of liaison of LDCs, because the procurement actually covers the whole of the East Midland, although we are here talking about Leicestershire.
Welcome, Sarah.
I think the papers have been submitted to the committee. One of the papers submitted is basically the report from the Leicestershire Rutland Dental Committee. I'm just briefly going to go over it just to refresh where we are with it. As you know, intermediate minor oral surgery is a service provided outside general dental practice for people who have complex extractions and issues that general practitioners have, removing teeth in people's mouths. It could be wisdom teeth, impacted teeth, roots, etc. So patients are referred to the specialist services. The teeth are then removed by the specialist services. Patients then return back to the general dental practice to look after the patient's ongoing care. This system was set up to take the backlog, which was at the hospitals, right, and to basically save quite a lot of money of a patient going into hospital with the associated costs. The cost of running this service was probably, I'd say, a third of the hospital cost. And this is just general estimates, basically. The service has been provided quite successfully over several years. From the 1st of April, the ICBs became responsible for the service. There was an oral health needs assessment, minor oral surgery needs assessment done in December 2021. And the groups which were sort of targeted at that time were mainly to do with commissioners. We look at NHS England and Improvement Consultation website, NHS England Improvement Consultation app, NHS England and Improvement Twitter feed. There was primary care dental bulletin, local dental network, again, not accessible for public, emails to dental professionals, dental professional webinar, and engagement sessions for the ICSs, which was just been commissioned recently. And the other group was the people who've been referred to the services. There was 20% of those who were mailed, and there were 5,000 emails sent out. The responses, in our opinion, were quite poor. The numbers which we're talking about is 20 patients responded, right? Member of the public, 29, right? The service providers, the dental professionals, 17 of them responded, which is probably quite a good amount out of the amount that we already have. And one non-dental professional, representative of voluntary sector. From our point of view, the numbers and the consultation which was run here and the conclusions drawn are flawed. The reason why we say that is because the representative group had not been emailed, or consultation for the public hadn't taken place, because the category mentioned here, the 9 categories, there's only one category, which is 20% of the referred patients were involved in the consultation. So to draw conclusions out of this report for us was unbelievable, basically. Okay, so we move on with the service had to be redeveloped and recommissioned. Presently, there are because I don't want to say wrong thing here. We have 11 sites, right? And it's going to go down to 4 in Leicestershire. And the 4 sites basically are, so on the 11 sites, we have 6 in Leicester, 1 in Colville, 1 in Hinckley, 1 in Loughborough, and 1 in Market Harborough. And that's going to go down to 1 in Northwest, 1 in the East, 1 in the South, and 1 in Colville, leaving Market Harborough, Hinckley, and Melton out of the picture completely, and Rutland. Right? It is expected that patients will travel. This is a conclusion drawn from the 20% of the patients who responded, not from, that's, the public consultation for me means consult the public, not the commissioners and all the other groups associated with it. So it was suggested from this analysis that the public will travel. They want to travel, they will travel. Now, if you can imagine somebody having a wisdom tooth out or a surgical extraction done, right, and having to travel long distances and going back on the bus and the carbon footprint and everything else associated with that, right? It's really a bad thing. It's like, you know, sending somebody who's going in for a day surgery at the hospital to go home on public transport. So I'm not sure whether that's been considered correctly. And maybe I'm talking too simple about it. Perhaps it can be justified. Our main concern is that the lot sort of redistribution that's been sort of brought forward, which is 4 sites from 7, right? And leaving out Hinckley, which is a large population, Loughborough, which is a large student population, and Melton, right? And expecting those people to travel those distances to get to centres where they need to be is a wrong decision to make. I think it needs to be looked upon again, and perhaps those areas need to be also commissioned within the same budget. The first question that we asked about is, what's broken with the existing system? Why is the existing system failing? The only thing which is missing from the existing system is conscious sedation, which is sedating a patient to do the treatment. That could be commissioned over and above the existing sites. Existing sites see patients within 8 to 10 weeks. It is proposed that we move on to an 18-week wait referral. So when you reduce the sites, the waiting list will just shoot up. So we think that it's not been considered properly. We think that it's not in the public's best interest to go ahead with this procurement, and the procurement needs to be paused and reviewed, right? And consultation with us, with the LDC, was there. We had a consultation with them, but there was no movement on it at all. There was no flexibility, and there was no, what you call, we will do this differently, or we will go and have a look at this, right? In the meantime, the process has already started. There's been 2 market engagements in October. They're hoping to launch the procurement in November, right? And currently, the system is still sort of safeguarded because the existing providers are providing the service, right? And the service is still continuous. It's not interrupted. So our main concerns are that we think that this report is not representing public consultation, right? It is not providing services in the best interest of the public, because that's what we're here for and not for anything else. It's also reduced the amount of remuneration to the specialist services. They've dropped the remuneration down by 23% without actually costing it out. The BDA, British Dental Association, tell us that we're below average in the country on the rate that exists now, which has not been uplisted for the last 12 years. Right? Yet we were told at the meeting that looking at the Midlands and the average cost which is there, we have to reduce the cost by 23%. From our point of view, if you're going to reduce the cost by 23%, that is going to have an impact on patient services, right? Because at the end of the day, behind all of that, there is a practice to run, there's staff to pay, there's materials to pay, and there's also other bills that practices have to pay out before even actually looking at what the income of the specialist would be. Based on the fact that, you know, we're saving almost 3/4 of expenses by a patient not going to the hospital, I'm not sure whether this is the correct sort of proportioning, and it's the correct strategy of reducing something by 23% without having, you know, proper justification and work out of it. So we would like that also to be costed out during the procurement and say, why do you think it's 143? Not randomly because the averages say that to you. Make a business case of it. We want value for money. So what does the value for money mean, right? Is the current system paying out too much money? And why did you pay out for 16 years like this, right? The system was running. And that's it. Those are the questions we have. Sorry about the broken down sort of presentation. I'm not used to presenting a report. Thank you.
And I've got a confession. I'm not used to actually listening to the issues. That I don't think this is the right forum. I think it sounds like it needs to be stepped back, because I don't feel this is the right forum to have argued those points out. I'm not sure whether we're all with you. I'm certainly not, because I don't understand how it's got to here without it being finalised, or those issues or that business plan being done in the first place. Mrs. Richardson.
I think we're really looking at the procurement and the actual service that's being provided, and how that actually how our residents are being affected by this. I don't see it any different to scrutinising an ICB report or whatever. We've actually been, or I was actually asked whether I could take this forward, and I felt a discussion was necessary, but I didn't feel Health and Wellbeing Board was the correct place. I thought Scrutiny was. It's not for us to make decisions, I feel, but I do think we should act on anything that we've been requested to look at.
At this stage, then, can I invite Kat to respond, please? Thank you.
Thank you, Chair. We've also got a couple of people who have joined virtually as well. So we've got Dr. Rizwana Lala, who's a consultant in dental public health, and Stephen Clayton, who's the local dental network chair.
Can I then ask if they want to have something to say or be involved? If you just raise your hand and I will get to you. Thank you.
So I think what may be helpful is if Di just gives a brief overview of the second paper that's in the pack, which is from the East Midlands Primary Care Team, who have produced that on behalf of the East Midlands ICBs. I do think there's something just in relation to your first point around responding to all of the respective points and the time that you've got within your meeting as well. So there may be something around getting a general sense of the concerns that have been expressed, what some of the responses are, what some of the mitigations have been that have been put in place, and hearing those at least as a starter for today. So that's probably my suggestion.
Thank you. Yes, thank you.
Thank you, Chair. As some of the items have been actually discussed in our colleague's paper just before me, I won't go through the whole paper because it is quite lengthy and I'm quite conscious of time. So I think if I take the paper as read, I'm happy to take questions at the end. If I just want to address, the purpose was to discuss and inform the outcome of the East Midlands Intermediate Minor Oral Surgery Service procurement process, dated 2022 to 2023, the next steps and the next recommendations with the procurement of the service. As our colleagues have said, this is now a delegated function to the ICB as of the 1st of April 2023, but there is a full support team that have gone across with that delegated function and previous NHS England team as well. We've discussed about there is 10 locations within Leicester, Leicestershire and Rutland. There's 6 in Leicester, Coalville, Hinckley, Loughborough and Market Harborough. There was an oral needs health assessment that was done in February 2022 by our public health colleagues, and that derived that the need for the commissioning was to be set on population, deprivation, general oral health, fluoridation, ethnicity and the current services and patient travel clinic alternatives and stakeholders' feedback. The recommendations that came out of that report was to look at basing the services to the public need. Looking at previous service provision, most of the services was actually delivered within the Leicester East area or Leicester E provider. We have actually been engaging with our colleagues within the LDC. We've met on a couple of occasions to look at next steps and the proposal. The decision was taken to abandon the procurement based on the evidence that had been submitted by bidders, the quality of the bids, legal advice was sought, and this was escalated through the ICB and ICS governance process. That decision was then relayed back to the providers and the bidders that was going to be paused or abandoned, and that the new procurement would be looked at and lessons would be learned. There has been 2 engagement meetings with providers recently, October time, and one a little bit after that. And those lessons have been learned and that information has been taken back. The new procurement or the proposal to re-procure the services, no dates have been set yet. So no procurement is up and running and is unlikely to be within this month. There are still lessons to be learned and things to be added into that procurement package. The items that our colleague has raised as concern, they have been assured and added into the package once the package is available to go out, which will be documentation process will be reviewed and revised. Cost analysis will be reviewed and shared before any procurement pack built into the pack and shared with potential bidders. There are engagement events taking part now and will be in the future, and that will be to help support bidders to be more successful when putting in a bid for those lots. Happy to take any further questions on that if there's any, or if there's any from the existing report that's been submitted.
Thank you, Madam Chairman. My comments start with really the document that went out for people to tender, to apply. And the failure rate, quality bids was poor with surprisingly high levels which failed various gateways. Now that just, I thought, well, what on earth's happening here? You know, how is it there's documentation so complicated that people are presumably in the industry and the profession for many years suddenly find they can't, or they're failing to fill it in correctly? I don't know. I just thought, what on earth's going on here? So then the next thing, then it did strike a note, 125.15. Currently providers are paid £174 for typical case fee, which has remained unchanged since 2012 and will be reduced to 141. And I just think, well, I don't know, maybe it's all political in a different sense to ours. I don't understand it. Because, you know, if you're saying we want people and it's that damn complicated, you've got to have a master's degree at trying to work your way through it all. I don't know. And then to actually undervalue a resource, I don't know. I'm just amazed. I don't know how the logic, if you come to it, I'm don't want to, you know, I'm just scrutinising facts. It's all here for us to read. But I don't understand it and I don't know the logic behind it. Thank you, Madam Chairman.
Sorry, Hannah.
Yeah. So yes, exactly that. I wanted to raise the matter. When we had the engagement process, I think the engagement with the public is essential. It is about the public. It's not about just the money or the service. It's about the public, the service that we provide. And when you see very little engagement and conclusions drawn out of it, is not understandable. When my colleague from the ICB tells me that most of the patients were seen in Leicester East, well, dental practitioners have an option to refer to the practices available which are there. If most of them went to east of Leicester, that does not mean that everybody wants to go to Leicester East. There may be others who went to other practices as well. So I don't really see any significance in that sort of finding that we have there. When we talk about the bidders' submissions, they spend hours and hours to fill in these forms. They engage professionals. This is all time consuming, costly, right, to fill in these forms. It's not the first time procurement has been done. So if so many bidders, the majority of them, fail to sort of meet the standard, the 60% threshold, there's definitely something wrong with the process, which is there. You know, it's not you know, like you said, you don't need a master's degree to fill in this procurement process. Right? Then there was an educational event to mitigate that in October, teaching people how to fill in a financial statement and other things as well. I'm not sure about the process. I'm sorry.
Thank you. Can I ask Sarah to come in, please?
I think we have various concerns. We have a concern that this second procurement doesn't seem very different from the first procurement, and we're not convinced as an LDC that it's going to be any more successful. The other thing about the costing is we've taken advice from the British Dental Association, and in fact they have a freedom of information order out to try and get these costs explained to them across the country. But certainly the advice we got from our neighbours in not very far away in the Midlands was that we were far from being on the high side. We were extremely low at the original cost, never mind the 20% off. And that is a big concern to us as to how practices are going to provide a safe and efficient service for this procurement. The last thing we want is for the procurement to fail. That does nobody any good. It doesn't do practices any good, and it certainly doesn't do patients any good.
Thank you, Mike.
Yeah, thank you, Chair. I'm not a member of the committee, but I'm just trying to work out what it is that Scrutiny can do, and I'll probably ask Ewan's advice as well. From my point of view, I've heard a few things. I've heard some comments in relation to process, which I really don't think falls within the remit of Scrutiny. I mean, we've heard some comment, you can argue a debate about a procurement process and what providers think of that process and whether the bids are any quality, but that's not for Scrutiny, that's between the Commissioner and the providers or the people who tender for it. Same with money. Again, I don't think it's for Scrutiny to consider whether or not the ICB have put sufficient funds into the bid in the first place. That needs to be resolved outside, and I'd like to ICB colleagues to kind of tell us how that would be done. There is something about the specification, whether the specification is asking for the right thing. And again, whether or not at a re-procurement that could come to Scrutiny for Scrutiny to actually consider the proposal in the way that our consultations come to Scrutiny might be a way of asking us to, of getting us to ask measured questions about the appropriateness of the specification as deprivation, everything else we were saying. The bit that's in my mind is about consultation, because I'm kind of hearing that there wasn't a sufficient consultation with the public for the procurement to be there. So again, I'd probably ask ICB colleagues to comment on that, but I guess I'm looking at you, and the kind of best described as the sufficiency of consultation is something that would be within the remit of the committee. So I'm just trying to sort of work out what's within our gift and what's for colleagues to describe how they take forward a grievance.
No, I would agree with you, Mike. I think it's up to the committee's entitled to comment on that. Possibly it might be worth asking the ICB to come back near the time. But yeah, ultimately all the committee could do is sort of make comments on how they think the consultation's been carried out and process.
Has somebody just put something in the chat?
Hi, yeah, I've put my hand up, but I don't know if you could see it. Rizwana Lala, consultant in dental public health.
I'm very sorry, I was looking at the bottom of the screen, so not the top, so I apologise for that.
No worries, no worries. I just wanted to come in on some of the points that were raised from a public health perspective. So the consultation and public consultation was part of the reason, was part of the kind of public health needs assessment. So what the LDC raised is that this service has been running for 16 years, and why do the commissioners feel the need to change it? We always look at, whether services are continuing to meet the needs of the population. So we regularly do a needs assessment, and that's what was done in this case. And what we found is that, the population, as you can imagine, and the population needs have changed quite a lot over, from 16 years. So in terms of the design of the service, it takes into account things like the health needs of the population, which are higher in particular areas of deprivation, looking at, the practices and what the practices were doing. So only one practice was doing a very, very high number of cases. Now, from a clinical kind of public health perspective, that is a concern, because what we know from the evidence, but also from the outcomes, that patients have much better outcomes if clinicians have very high experience rates of doing like a core number of cases. And then there were other things that were taken into account as well. So not all the services have sedation services. So what is happening in the current model is patient travel to one place, and if that place doesn't have a sedation service, then they have to be referred to another place. So the design of the pathway and the service is such that, the practices are located particularly in areas of deprivation where there's higher need, but also people are less able to travel in those areas because of cost, etc. But also that all the services have sedation, so people don't have to be referred in multiple sites. other aspect in terms of kind of that streamlining. And these things we know from the evidence base, but also, gold standards of commissioning, but also some of the things that emerged from the consultation. So the consultation kind of was backing up some of the evidence that we know and some of the needs that we're seeing from other aspects. So the consultation was only one part of the needs assessment, and it was triangulated with other facets, and we're looking at the broader kind of public health picture. So, I hope that kind of addresses some of the concerns that are raised in terms of, why are we trying to fix something that essentially has been working for 16 years? It is something that we need to do, that, we need to continually review whether the service is of, meeting the needs of the population, and also continually look towards improving the service, i.e. not have this kind of two-step model where there isn't sedation available.
Mr. Charlesworth.
Thank you, Chair. I'm going to be brief because time's short. Whether this should be here or not, it's immaterial at the moment. We're discussing it anyway. It's clear the relationship between the providers and the bidders could be better, and I hope you can work together to resolve this in an amicable way. That's my wish anyway, as part of scrutiny. I just have one question. One observation. If what I've read and heard is right, that it's going from 11 places to 4, and that the price is going down even after a period of 10 years, I know the criteria is being changed as part of the process, but it sounds like it's dumbing down to me. Is that because the demand isn't there? I don't know. But my one real question is, it's going to have to carry on because the procurement service failed. Are the current providers, were any of the bidders the current providers? Because if so, that raises a really serious question.
Who can answer that question? Who would like to? I've got at the back of me, and I can't see. Is it Stephen? Begins with S.
It is.
Yes.
Stephen Clayton. I'm Local Dental Network Chair and also Senior Clinical Dental Advisor working with the ICB. Now, I have to say at the outset, I was not a part of this procurement, so I don't know the details. However, I think it's a fair and reasonable guess that at least some of the current service incumbents did put in bids. But I want to stress, because I have sought assurance on this point, although the bid was abandoned and most of the bids, if not all, failed to make it through the various quality gateways, these were not clinical quality gateways. There's been much debate here about what the Health Overview and Scrutiny Committee can and can't do, and I'm no expert on that at all. But I think if you want to take away one thing at the moment, it is that although the ICB consider there are ways that the service can be streamlined, particularly with avoiding the two-step process if you require conscious sedation, as Rizwana outlined earlier, there is no suggestion whatsoever to suggest the current service has any clinical problems at the moment. Your local population are still at the moment receiving a safe service in terms of intermediate minor oral surgery, and the ICB acted very quickly to extend contracts of incumbents to make sure there was no interruption to service. There is a work in progress going on here, without a shadow of a doubt. I cannot say why exactly the procurement was abandoned. I do know it's something that, as an ICB, we hate to do. As someone who is a clinician himself, I know it's awful. The one thing, I'm not disagreeing with Dr. Moti at all. Whether you need a master's degree to fill in these bids for procurements, I couldn't say. But you need to have a lot of skill to fill them in properly, and these skills are not clinical skills. And my biggest concern is that those delivering this service are really good clinicians. That may mean they're not so great at writing bids that tick all the boxes for finance and other governance issues that my colleagues at the ICB need to see. And I suspect that is part of the problem here. But I would really ask this committee to take away the one solid fact at the moment: there is no concern with the clinical safety of the service being provided across LLR at this time.
Thank you, Stephen. Mr. Muir.
Cheers, thank you, Chair. Yes, I agree, Ms. Charlesworth. It's in front of us, so if it should have come to us or not, it doesn't matter. We can comment, and I want to make a comment. I think I used this service to get my wisdom tooth out about 6 or 7 years ago. So I'll declare an interest, but it worked perfectly well. I went to my dentist. They said, you need your wisdom tooth out, and go to another dentist. I was referred, was seen within 8 weeks, I think. But in those 8 weeks, I had pain. So when you're talking about an outcome for patients and service users, if you're now stretching it from 8 to 10 weeks and you're stretching it to 16, 17, 20 weeks or plus, yeah, that's a problem, because they have to then live with that pain for that extra period of time. The other thing is that when you narrow the numbers down from 11 to 4, potentially, yes, you might concentrate the services, and the person that does it or the clinics that do it have more turnover. What happens if they can't manage? There's capacity issues in those service providers and issues. But also, I live in Loughborough, and I'm aghast that Loughborough isn't one of these service centres. It's a huge population. We have transient people that live there, students, but in its own right, it's the second largest, or it's the largest town outside of the city of Leicester. So I would have expected, Loughborough to be being provided for by the ICB. And if you're thinking that actually, yeah, people in Loughborough could travel into Leicester, then that's probably more pressure into Leicester. And if I was going to go into Leicester, then why not just send me to the hospital? That would be my thought. If I'm going to travel into somewhere, provide it in the hospital. The Royal is just a short walk away from the train station. I'm not saying that's where it should be, by the way. I'm just saying that's would have been my thinking as a general member of the public. The second point is the cost. I can understand everybody's under cost pressure, but one thing we've learned over the last year is that costs are going up astronomically, and I don't think it's fair on a service to say, actually, yeah, we're going to reduce you from 11 to 4 because of the sedation and the numbers and the flows, which I don't know how many people need sedation that access this service, but cost pressures to reduce it by 25%, 24%, wherever it was. I don't know. Are we going to get value for money? Are there going to be some cost cutting happening? Are people going to get the service that the NHS wants them to receive? And the final point I want to make is you can't get an NHS dentist. If you look at all the social media at the moment, people are desperately asking where they can access NHS dentist care. So it's not a good message to send out. Actually, we're reorganising this or redoing this to provide less centres for you to go to. Because if you're a general member of the public, you're not going to see everything else. You're just going to see the 11 down to 4, and that you're going to have to travel. And not everybody can travel. By the way, not everybody has that accessibility. So it's just one of those that are, I don't know what we can do as an outcome, but the ICB are here. And if you ask me to choose a side, I'm not going to. But if you ask me to choose a side, from my comments, you can understand, as a layperson who really doesn't have any interest in either camp apart from wanting to access the service, that's the kind of questions I'd be asking. Thank you.
I just come back a little bit on the finance side. Absolutely take the points on board around the finances, but just to give you some kind of assurance in terms of the interest, there was a number of bids across all the lots for the whole of the East Midlands, and currently the contract's on a cost by case basis, so they only get paid for what they actually do. The new model would give them a guaranteed income. So yes, appreciate that there are larger sites, but they will obviously get a larger number and a guaranteed income. And in relation to some of the reasons for the failure, it could actually be attached to that, because some of the bids applied were for more than one lot, and obviously we need to make sure that we're getting that financial sustain, that they can manage that contract. And also there's some of them needed guarantors. And some of the guarantors was not been sufficient to underwrite the risk of the wider and the big contract. So just to reiterate, I think just about what Steve said, there's no concerns clinically. It was just around the bids, and so, you know, if a deadline's a deadline in a procurement, unfortunately, there's no flexibility on that. So if a deadline's missed, then we can't take that into account. But what we have done is the education sessions. We've run 2 education sessions to try and improve the quality of the bids and go through the, you know, in real detail around what you know, what they're looking for to help support the bids going forward. So we're hopeful that when we do go out to procurement, when that is agreed, that we will see a significant increase in the quality.
Thank you.
Just picking up on what Liz has said and going back to the gentleman's question earlier on about have we made the process too difficult for people to be part of. So the high level themes where the bidders were deemed as to fail on the improvements and where we've been working or will be working with bidders in the future, basically around the financial standings, the premises, information governance and the core questions. And then it was a failing on non-responders to clarification questions. Sorry, struggled with that a bit. So that's where we would have gone back to bidders, asking them for more information and more details, and then they have not responded to the procurement team. So therefore that is classed as a failure on that tense.
Can I just start by saying that we very much want this procurement to work because we want it for our members who are dentists and we want it for the patients. At the moment, there are no sedation services in Leicestershire at all. So obviously, if they were procured, that would be an improvement for patients. I don't think we came to this meeting with the idea that we were going to present you with a problem about money that you were going to sort for us. What we did want to make very clear is that in our view, it is going to reduce the availability for for constituents in Leicestershire, for want of a better word, and that is a big concern. We also raised with the ICBs the concerns, as you said, that as the procurement had failed previously, and some of them bidders may already hold contracts. And again, we were reassured that there was no concern about the actual clinical treatment provided, nor are we suggesting that there was either ways. I hope that the relationship hasn't broken down because we certainly want it to work.
Thank you for that. I'm going to call it to a close now, and safe in the knowledge that the clinical treatment that's being provided at the moment is safe and it's working well. And I think that I would invite the ICB to come back at a later stage to tell us how, or to explain to us how this process has been altered and being more effective, and hopefully a lot more providers will come forward and manage to get through the process, because I think that is the problem. It is the process. So thank you very much for that discussion. Thank you.
Thank you. Good afternoon.
I know. Oh. The next one is agenda 11. It's on your pages 165 to 258. And it's the review of homeless support services. Mike Sandys, Director of Public Health, is going to be supported by Joshna Mavaj, Assistant Director, Commissioning Public Health, in presenting this report. I do apologise.
Thank you, Chair. I think it's the other way around, actually. I'm supporting Joshna, in all honesty.
All right.
No such problems with a lack of public consultation responses on this one. Just to remind Scrutiny that we were here last time round to seek Scrutiny's views on our proposed new model of supporting the health and wellbeing of the homeless. We said we'd come back this time round with a dedicated report on the consultation responses. That's what's in the pack, and then I'll hand over to Joshna to take us through a summary of the consultation responses.
Good afternoon, everyone. I'll take the report as read, so I'll try to sort of cut out the time that I spend going through, if that's all right. Just in terms of the consultation feedback, which is the bit that I wanted to focus on, we've received a really good response, so over 150 responses to the questionnaire. We had really good attendance at the information sessions, really good response from service users themselves as well. The responses that we had, mainly from those who have been or are being supported by the Homeless Support Service, and also from staff providing homeless support services, so reaching the target cohort that we were trying to get to as well. As the report identifies, 74% of respondents to the questionnaire disagreed with the proposal that we put forward, with the greatest proportion coming from staff of homeless support services and those being or previously having been supported by the service. Where there was support, the reason centred around recognising the need to focus on prevention, which is what the proposed model is focusing on, recognising the need to provide wider support, so coverage across Leicestershire, and the benefit in having a single point of contact. There were multiple reasons put forward for why respondents disagreed with the proposal. The main ones being that the support provided at the Falcon Centre is highly valued, concerns over the potential negative impact if the Falcon Centre closes. There was a comment around lack of awareness of existing public health services, concerns raised over accessibility of the proposed offer, and concerns over the loss of targeted support. Additional feedback I've summarised within paragraph 35 of the report, but within that I've also put some commentary that responds to the comments. And those comments link specifically to the proposal, because what we were finding was a lot of the responses weren't about the proposal itself, it was about broader homelessness support and services. In terms of the key themes that came out in terms of the comments, the matters, some of the commentary, the comments that were provided, some of those were matters that will be addressed within the proposed service. So strengthening the focus on prevention, for example. Some of them are matters that will be addressed as part of implementation of the future model. So, for example, recognising that we do need to do a lot of work around awareness raising of the existing services and strengthening our referral pathways. Some of those comments were around matters that fall outside of the responsibility of the council, so things like hostel accommodation and factors around complex health issues. And some of the matters were addressed through the development of a set of frequently asked questions. So during the early part of the consultation, where there were repetitive themes coming up, we responded to that as part of the consultation by developing some question and answers that were then put onto the web page and also as part of the paperwork. We also asked for alternative suggestions to the service model, and again there's a table within paragraph 38 that provides details on the suggestions. One of the challenges we had with that was a lot of the suggestions were ongoing criticisms of the proposal rather than actual suggestions for alternative service models. We did consider the responses that were put forward, and again there's commentary within the table as to why we felt those options were not viable from the point of view of this particular service review. So we're not saying it's not viable as a whole, but this was about a review of the current service. So based on looking at the need, a review of existing provision, our responsibilities as a county council, a review of the consultation responses, the recommendation that we intend to put forward to Cabinet is for the county council to cease funding a dedicated homeless support service and instead to provide that support via the council's existing public health services. This will predominantly be through the front door approach provided by First Contact Plus, and further detail of that model is described in paragraphs 41 to 46 of the report. And also within paragraph 47, we've put a process map showing how we see that pathway working if the proposed model is approved. So in terms of next steps, we will take the recommendation to the Cabinet on the 24th of November alongside the consultation findings. And if approved, we'll commence a period of implementation of the model with a view to the new offer being in place from the 1st of April, and implementation will consider the key consultation findings around raising awareness, strengthening the pathways, so ensuring that we've got a robust communications plan to promote the offer, and also look at development of really strong performance indicators to monitor the new service once implemented to show that it's an improvement from the current provision.
Thank you very much for that, Joshua. Mr. Charlesworth.
Thank you, Chair. I'll be brief. Fairly predictable responses from the responders. No change there. I'm the chair of the Finance Committee at Oban Wigston, and I have to say that the pressure from homelessness on us now is really putting a strain and a risk to our finances. We shall set a budget next year, but going forward, homelessness is one of the biggest cost pressures we have, and it doesn't bode well for the future. Let it go to Cabinet. I think we've said as much as we need to on this.
Mr. Muir. Yes, please do, Mike.
I mean, I don't know what Josh can say. I suppose from my point of view is, yeah, and I think for all districts, homelessness is, again, I'd come back to the point of we're not actually scrapping, we're scrapping a dedicated homelessness support offer provided through the commissioned activity, but we are still providing through local area contact and first contact plus that support. And in all honesty, by providing that across the county in the way that we are, I'd like to think we would be supporting more people than we would through the Falcon Centre. So within that, I mean, Josh knows the detail. I would love to see, and one of the opportunities I think for this is a better join up with housing officers' pathways. So actually we are offering what support we can, which might enable them to be a bit more financially self-sufficient, improve their health. And I don't know if we'll choke off the demand on districts, but at least there's a join up there that possibly we're not seeing with the current service.
Mrs. Richardson.
Thanks. I think it's all through this, it's really got dragged into whether the Falcon Centre closes or not. And I think we have to remember that this is about a service that we provide, and it's about in-reach and outreach that we've been providing. The new proposal has been really thought through to try and join up, to try and ensure we get people before they become homeless, so those at risk. And by working with the districts, we're hoping to be able to turn it from, 30 beds at a time at Falcon Centre or wherever else, to about 2,500 could possibly be pulled through into First Contact Plus to be then given the additional help. And we'll also be able to monitor those people a lot better. So we're looking at the whole of the county and trying to look to the health and well-being of people who are at risk of homelessness before they end up, needing going out on the streets or anything like that. So we feel this is a better way and a better use of the financing. Plus, this would have gone out to recommissioning anyway. And there was no guarantee that Falcon would get the bid. So, I want us to maintain, to keep our eyes on what we're actually discussing and not what has come out within social media, etc. Thank you.
Thank you for that. Mr. Muir.
Cheers. Thank you, Chair. I think, Mike, you opened with saying that no problem with the consultation here, and I think that's welcome. It doesn't matter who the respondents are. It's welcome that we do get the responses, because we've sat on committees before, all of us, where we said actually there's only 6 people in the whole of Leicestershire who've responded back to this consultation. So I welcome it. I welcome people having their say, because at the end of the day, that's what we want. But I have some concerns. I've not sat on this committee originally. I'm subbing for Betty today, so for Mrs. Newton today. So I just wanted to touch on this First Contact Plus, if you don't mind me asking. So say I'm homeless today and I have some health issues that I need, that I have as well, and I contact First Contact. So what's the vision there? How are they able to help me and support me get off the streets or get into a provision where I'm not on the streets, for example, or deemed homeless.
So if an individual is rough sleeping, it's a different initiative. It's the Rough Sleepers Initiative that picks up and supports, and that's a district-led provision. If it's an individual presenting with a housing issue alongside a health issue, the pathway would be that they would present to the district housing team, where they would then be talked through a housing support plan. At the same time, the way we want the pathway to work is that would then, with consent from the individual, result in a referral to First Contact Plus, and that's when a full assessment, a triage process will then take place. And the idea is then that the housing need and the health need is being met hand in hand, rather than trying to do one and then leaving one till further down the line. Doing that triage assessment, a First Contact Plus will then ascertain the type of support that's needed. Usually we find that the homelessness is linked to the health, or health linked to the housing situation. So if there's issues around debt, benefits advice, that referral can be submitted straight away. And First Contact Plus have the added benefit that they can monitor that referral as well. So if there isn't been a response, they can follow that up. So it's not just simply referring an individual and then leaving it be. And then if it's a health specific service, so for example, substance misuse, we can refer to our Turning Point, our substance misuse treatment provider directly, and Turning Point will then make that direct contact and provide that one-to-one support. So it's going to be bespoke to the individual based on their need.
So thank you very much for that, because that really explains it, and I'm clear in exactly what you said. So now I've been referred to First Contact Plus by the district council, let's say whichever district council it is, but I still haven't had a provision yet, whereas at the moment in time, yes, it might be limited to X amount of bed space or room space. I may potentially have a roof over my head, but here I still haven't had a roof over my head. By going to First Contact Plus, is it only just dealing with the health issues aspect of it? Pure and simple, is that what you're clarifying? So that's fine. I don't need a response on that, Mike. I was just clarifying that in my own mind. Okay, so my second question is the £300,000 savings. Do we think that, Mrs. Richard, you touched on about 2,500 people coming through. What's the actual demand at this moment in time? And is that £300,000 actually going to get swallowed up by the extra demand because districts are then referring more people to us through First Contact Plus, as an example?
Part of the COVID sort of recovery response, we did increase the workforce around the local area coordinators, around First Contact Plus. So we're confident that we can manage the demand. I think it's just monitoring to see how things go, because with this kind of service, we want that demand to come through. It's not something that we're trying to limit. So I think it's just keeping an eye on it. We're forecasting it based on the number of individuals that are presenting to districts at the moment, and that we think we can confidently manage.
Yeah, if you indulge me, one final point, and then I'll shut up, as they say. So we've had this consultation, and we know the service that is being provided at this moment in time. And Mrs. Richards is right. We would have gone out to consultation, and it would have been whichever bidder we thought was most suitable at that moment in time. What's the thinking behind changing that model into this model? And I wanted to say, what triggered the change? Is it budgetary pressures, or is it that we're trying to reach more people?
So we started this work because the contract for the current service was coming to an end at the end of March of next year. The MTFS came after that, so actually we were already doing a review of the current provision. Within the report, I did put some challenges that we've got with the current model. The coverage isn't as wide in terms of needing that Leicestershire-wide coverage. Everybody's congregating to the Falcon Centre, and it's being seen as that is the support. And we don't want it to be seen that way. We want it to be seen as a bigger offer. We're also seeing that the focus has shifted towards supporting individuals with more complex needs, and this model was never designed for that. It was for more low to moderate need, with the view that there was support to access complex services through the NHS, that the staff are not trained to provide that level of support, and that was never meant to be there. But we're seeing that that's where this service was going, and we were just concerned that it wasn't covering that lower level health and wellbeing need that we wanted it to focus on.
Thank you. Are there any more comments from councillors? Mr. Pendleton.
Thank you, Chair. I think Park and Centre, and if I remember, First Contact Plus must have initially developed about the same time. What I have seen from First Contact Plus is that it's been far more holistic and far more widespread over the 7 district and borough councils, and therefore able to respond far more quickly and broadly to this particular type of homelessness. And I really do think that when we're looking at 2 parallel schemes which are running, that First Contact Plus has the potential to do far more holistically than a specific centre dedicated, I'm sure, all perfectly well to a smaller amount of individuals. And I really do, Chairman, feel that we ought to back this in terms of where this report says we should be going. And I have no qualms whatsoever in suggesting we move business accordingly. Thank you.
Thank you for that, Mr. Pendleton. So it's the view of the committee that this will go to Cabinet and it's approved from this committee. Thank you. Right, so we go to item 12, which is whole school approach to food and nutrition. Welcome, Sally Valence, Head of Service Public Health, is going to help Mike Sandys present the report. Got a lot of help today. Mike.
Same again, yeah. Luckily, I've got an excellent team that makes up for my many shortcomings. So this is the second, basically, actually, what Scrutiny's got today are the 3 main service reductions that we put in the budget that went to full council in February, all of which are at different stages in the process. So homelessness is the one that's most through the journey because it goes to Cabinet for a proposal. Physical activity is the one that follows on from Sally with food. Whole school food approach was another one of ours, which is probably more at the start of that particular journey in terms of remodelling and saving money. So over to Sally.
Thank you. Hi, everybody. So just briefly to set out, we fund the Soil Association to work with primary schools across Leicestershire. That's to develop a food approach with children. The programme includes things such as understanding where food comes from, how to eat a healthy diet, what constitutes a healthy diet, and can link in with schools' kind of growing programmes if they're growing their own, if they have the space. So it's that kind of work and approach with schools. Schools can then go on to gain a bronze, silver or gold level of accreditation for the work if they wish to. This contract is coming to an end at the moment, so we're needing to review that, and we also have a savings target linked to the piece of work. So we're needing to look at this at the moment from a public health point of view. So we're proposing a new offer to schools, one that's more focused on achieving the bronze level of award. So it's that ensuring a broader range can achieve the bronze level. It's also focusing increasingly on schools with high levels of overweight children. So it's that's increasing our focus on those schools that have children that need that support more greatly. So there will still be an offer for all schools to access, which is online, including training materials and tools that they can use. And that offer currently stands with schools, so many of them are already using it and are familiar with them. The change to the offer is a reduction in the staff time that's available to those schools to support them through that accreditation. And as I say, that will be more targeted on those schools looking to achieve the bronze and with higher levels of overweight children. So this is a proposal to run for the next 2 years. The idea is over that period of time, we would look to do a wider review of our food and nutrition offer across public health, and obviously consider in the longer term what offer is suitable for children and young people going forwards. So we're in a period of engagement at the moment. We're engaging with schools. As we understand it, we're not under a duty to consult in detail, but we're wanting to have the conversation and understand the need and the impact from the schools' points of view. The engagement started on the 4th of October. It runs until the 21st of November. So we're about halfway through that at the moment. And we're looking to take a final report to Cabinet early next year. So far we've had 13 schools responding to the survey. And just to give you a bit of an idea of the sorts of responses, we've had just over half indicating that they either strongly agree or they tend to agree with the proposals. The kinds of comments we've had are that they understand the need to prioritise, and it seems like a kind of sensible route to prioritising those schools that have the greatest number of overweight children. We've had a school saying they neither disagree or agree, and we've had 5 schools tending to or strongly disagreeing, and the comments that accompany those that are disagreeing with the proposal really talk about the impact of the loss of the staff support and what that will mean for those schools. Overall, schools are indicating that they've received a really positive response, those that have engaged in the programme, that this has really supported children in the school and has supported the school community more widely, including the staff at the schools. So we can see that it's a programme that's welcomed by our schools. It's just a kind of mixed bag in terms of being on board with the changes. So this is being brought here today to seek your input to that engagement process so that we can include all of that feedback and take it to Cabinet, as I say, in the new year. That's my summary for you. Thank you.
And at the point of me wanting to speak, I switched my microphone off. So it had been on. So Mr. Harrison, please.
Thank you, Madam Chairman. Well, I feel we ought to accept the report. We know the implications of it, but we're still there. We're still trying to do good things, which is important. We can't offer the full menu, and that's obvious because of other reasons that we face, considerations on the MTF. So, yeah, I'd move, Madam Chairman, that we accept this report. Thank you.
Is that the view of the committee?
Yeah.
Thank you very much.
Sorry, I wanted to
comment. Sorry, Mr. Mayor.
Apologies. Sorry. We are where we are. I just wanted to add a note of caution that actually this is some of them, targeting some of the most vulnerable, unhealthiest children that we have who may develop health issues going forward. So it is important that it is targeted at that younger age, and I recognise we have to make an MTFS saving, but at least some provision is better than no provision. But also, I think on the comments from the schools that have come back to say actually it's going to impact them more proportionately, maybe we can give them some more targeted help in the short term to help them overcome that loss of staff, for example. Because this is going to be a long-term proposal for the next couple of years. So maybe the few months where they don't have that support, maybe we can help them bridge that gap and embed into the new system. Thank you. That was going to be my comment.
Mike.
Yeah. Thanks for the question. I mean, as always with these things, I'd rather not be cutting anything, but in the context of that, it is making the best of a bad job, pending a review of our whole approach to food and diet. I mean, Sally knows better than me, but the way we've done it is in terms of the support that would still be available in at least in the 2 years, is to target that on those areas with the highest rates of childhood obesity. So we have tried to take into account the inequalities angle around childhood obesity in the new proposal. That'd be a fair summary.
But of course, those primary schools can still go for silver and gold, and they have got the data, the information to do that online, but not the staff support.
Exactly that, yes. So they absolutely can still go for the accreditation, and there is the online support available to them and training online, a number of kind of toolkits to support them in doing that. And obviously we'd be behind them wanting to do that as well. We're asking questions around how many think they're likely to continue on to do that. We are likely to lose a few, I think, from the responses, but there are a number that propose to continue with that programme, even in the face of this changed offer. So we do think a number of schools will continue, and as Mike has said, those with the greatest need, as shown through those obesity levels, will receive that staffed support on top.
So mainly the committee here understands the financial pressures, and they understand that the service is still there and targeting the most vulnerable there. So we approve. Thank you. So now we go on to item 13. Welcome Elizabeth Orton, consultant in public health, and she's going to help Mike present the report.
You know what I'm going to say? So there's no one else in the department, just in case you think that's it.
That's it. Physical activity programme. Thank you.
Thanks, Mike. Thank you, Chair. So again, I'm going to take the report as read and just give you a summary, and obviously happy to take questions afterwards. So we know in Leicestershire that about a quarter of people do less than 30 minutes activity per week, and that's what we classify as inactive. And we know that being inactive really does carry significant health risks, both in terms of prevention and management of long-term conditions. We know people in marginalised groups and people with disabilities, older people and women are groups that are more likely to be inactive or more likely to be less active. And we know that there are significant barriers to physical activity, such as cost, proximity to where there might be provision available, the quality of the environment that you live in, how nice the spaces are outside for you to be active in, for example. So all of those things contribute to whether or not an individual is likely to be active. And so we know that if we can support people to go from being inactive, doing less than 30 minutes a week, to doing some activity or more than 30 minutes a week, that's where we have the greatest health gains. And there's quite a lot of evidence to support that. And so in Leicestershire, the way that we have designed our provision of physical activity programmes that we fund, because obviously we only fund a part of the system. There's school PE, there's the leisure centres in the district councils and so on. So the part that we fund is through a grant that goes to the district councils, and then what we call school sports physical activity networks, and they're a kind of slightly historic structure that was funded through the Youth Sport Trust, and they are organisations that sit in schools and then help us deliver our physical activity programmes in the school settings. That's in addition to the school PE provision. And then we also fund our active partnership, Active Together, who are part funded through Sport England and part funded through us. So together, the grant, which is split up on a needs basis out to the district councils and the school sports networks, is how we've allocated the funding, and we've specified kind of what we expect to see for that grant, what kinds of things can be delivered in terms of that grant agreement. And you can see in table 1 that it's quite a complex system of things that we don't commission it, that the grant funds from at the top, if you like, of the pyramid, very specialist programmes which are geared towards very specific health conditions, so to reduce the risk of falls in older adults, to improve the pain associated with back pain, with cardiac recovery. And so these very specialist programmes, right the way down to the very universal widespread programmes, so the less specialised, larger population footprint, things like campaigns, encouraging mass participation sports like park runs, encouraging things like walks from practices, health walks and so on. So there's quite a broad range of offer that we currently fund. The proposals, so we're tasked with identifying savings to contribute to the MTFS. And so the proposal that we've put together really focuses on keeping that specialist tier of provision, because that they're highly skilled instructors and they have very significant improvements in people's conditions, and we've got really great feedback from those programs to illustrate that. And we really want to retain that capacity in the workforce, and then retain that kind of what we call the left shift, the big population level emphasis that we have on using campaigns, the walking groups, the level 1, 0 and 1 provision that we would call it. We also want to keep the offer where people have a health condition and they're identified either by a health professional or other kind of allied health professionals might recommend that those individuals are more active. So that's what would have been called exercise on referral in the past. We want to keep that tier of offer as well. So slightly less specialist than those really targeted provision, but still aimed at people with a health condition. What we would be proposing to reduce is what we call the level 2 programs, which are the community-based and school-based programs that are less targeted, but less specialised. They probably have a broader reach in terms of who accesses those programs. And this is it, bearing in mind that, you know, schools do have a PE provision, they do have the school's premium to buy in extra provision, and then we do have the leisure services that are under contract to deliver programs as well. So it would be a removal of our contribution. There's also the graduate training programme, which is to increase the capacity of the workforce around physical activity, taking graduates, giving them work experience. We're proposing that wouldn't be our core business, and so we remove the funding from that as well. So that's that's kind of the model that we're proposing to change to. We have been out to public consultation. It closes today, and Scrutiny is part of that consultation. So far, we also have had quite a good response to this. We've had over 320 responses to that consultation. Obviously, it's too early to tell you exactly the detailed breakdown of that consultation response, because it was literally still coming in till this morning. But what we know so far from the consultation responses that we had in at the time of writing the paper is that, yes, people would agree that we don't want to cut physical activity programs. It's an important public health intervention and approach. But if we are going to cut the funding for it, that we do focus on those who are most at risk of ill health, those conditions where we know that there's evidence-based programs that can improve those health conditions, and also focus on what we can do at the large scale, working with the planners, working with, you know, healthy housing developments, making sure there's opportunities for people to be active, and then working on the campaigns and the mass encouraging the mass program participation. There's obviously quite a great deal of support for continuing with supporting children to be physically active, and we're really keen to retain the very specialist provision that we have, helping children develop the fundamental skills like hopping, skipping, catching a ball. So that will mean that they're more likely to have lifelong interest in being active if they've got those skills. So we really want to retain that provision. So overall, that's kind of a summary of the model. Happy to take questions on that. Mr. Charlesworth.
Yeah, just two questions. The current model of the 693,000 that goes to districts, is that on a population basis distributed, you know, according to your population size?
Yes, we have a formula that's based on the population size and the proportion of children who are obese, socioeconomic deprivation. There's several different factors that contribute to creating a formula for each district.
I think after this meeting you could send me the breakdown for districts of what they get.
Do you mean the current funding?
Yeah,
just not the formula.
Not the formula, just the figures. And the second question is, does that go straight to the district council and then they deal with the active provision and the schools, or do they then pass it on?
Turn it off. Yes, we have a grant agreement with the district councils. Every year we redo that grant agreement, and then they have a kind of sub agreement with the school sports partnerships for the school-based delivery, and then most of them will do their own in-house provision at that point rather than sub-commissioning. There's a bit of a mixed model really, but yeah, that's how it works.
Okay, no more comment. Oh, Mr. Harrison.
Initially sad, because sports in my blood as a former international athlete, and when I'm not busy doing jobs like this, I'm working in a sports leisure village project involved in all sorts of sport. But I think we're at a point where we've got to stick to our knitting here in the county, and I think what you're doing, we work closely with a district council, and they have leisure sports officers and all sorts, so they have an infrastructure that we key into. So it's never welcome, because people always surmise that these things are going to do good. But when you get down to the shop floor and you see what the results is from schools and all of this money that goes there, you know, it's not a rush. It's very selective. So the work the schools are doing in their own educational methods is very, very good to get young people to be involved in sport. But I think the move is sensible ultimately. We're still there in a format, but, you know, we're just really letting the people who are supposed to have the real responsibility in education, and not us on the sidelines feeding it, because then people become totally reliable on it, and then, you know, we have our own service provisions here that are under pressure that we've really got to look after ourselves. So I would move we accept the programme, this paper, Madam Chairman. Thank you.
Mike.
Yeah, and just to respond to that one, and sort of Liz can chip in as well. And it's a fair point, really, and I suppose a lot of the service proposals we've done, it comes back to kind of what's the public health role in that, which is really to advocate and to try and, you know, it's about population change. Ultimately, it should be about getting the most people as fit as they can be. So within that point, I suppose, you know, we have to focus today on a service reduction, but it shouldn't lose track of an overall approach to physical activity, with Liz and colleagues working with environment, transport and districts around the planning and the wider determinants bit, because the more you can build physical activity in, you know, that is the bit that we can lead on. Yeah. Thus, building it in as part of everyday life is the easiest thing to do. Within the context of the health bit, then I think we've made hopefully a reasonable case about preserving funding for specific programmes related to health conditions, because that is something that if we don't commission it, nobody else will. But you're right, I mean, that is about other people stepping up to the plate, and they're doing part of the system as well, be it districts with their leisure offer, the discretionary spend around that, and the education bit. So, you know, so just to agree with you, but I suppose in the context of that doesn't mean that we're pulling away from physical activity, far from it. We just need to make certain we major on those bits where we think we can make the most difference, or is particularly our responsibility.
Thank you. And I was particularly surprised that to find that we did fund a graduate training programme anyway, because there's quite a few things on there that I wouldn't have thought that it was a natural thing for the county to fund.
Yeah, and I mean, to be fair, there's a whole debate around the workforce for sports development, and you know, if John Bird from Active Together was here, he'd say a lot of people involved in the higher level jobs, you know, around Active Together have gone on to bigger and better things. And the graduate trainee scheme actually has been quite successful at building the pipeline of workforce development. But it's that point, sort of, it's probably not our core job. So I can see there would be an implication. I can see from the whole sector point of view, it's a good thing, but it's not for us.
Okay, so the purpose of this report was to form part of the consultation and note our comments. So thank you very much. Right. And oh yes, it doesn't say anything about anybody else supporting Mike now. So You're riding solo here.
Oh.
So we're on item 14, which is Director of Public Health Annual Report.
Thank you, Chair.
Thank
Yeah, no support. I'm going to have to fly solo, and even my lead member's trying to beat a retreat out of the room. There we go. What can I do?
Sorry.
So, as it says, the purpose of the report is to present my annual report. It being a statutory duty on me to produce an independent report on the health of the population. The quick amongst you will have noticed there is no reference to a report in either 2020, 21 or 2022, because it is the first time since 2019 that I've published a report for what I hope, as I said in the forward, is understandable reasons. Obviously, COVID got in the way of producing a report in 20 and 21. 22, I could have done a report, but there was a load of abusive WhatsApp messages I was having to delete off my phone, which kind of took me last year. So anyway, so this year is a chance to get back on track by producing one. I've gone back to first base really, which is normally DPH theme it around a topic, and I've done that in the past. You choose a particular topic and go in depth about it. But really the statutory guidance is around presenting a report on the health of the public with a view towards advocating for the changes in the health of the population and making recommendations for commissioners to take forward. So I've done a fairly broad brush one, which is really just to kind of say, look, give us a picture of our indicators around health. How are we doing in Leicestershire? And I picked it up with Victoria Rice, who works in the data and business intelligence team, who sort of said, I said, have you got a dashboard that can tell me this picture? To which she said quite reasonably, well, actually, yeah, it's the health and wellbeing dashboard. So I have fairly unashamedly ripped off the Health and Wellbeing Board's dashboard and put it in my annual report, because it does detail 100+ indicators across all stages of life, from birth to death, and cross-cutting themes of mental health and health inequalities. So I've lifted that, and against all those kind of areas, we've put in place a narrative, if you like, along how are we doing in Leicestershire against the national average, how are we doing in comparison with the 15 other most similar local authorities to Leicestershire across the country. Brief summary, because we're over time really, is, as you can see, I mean, as you would expect, Leicestershire is a pretty healthy place. We've got far more indicators above the national average than we have below. And we've also got quite a few pockets of kind of top 3 in our comparator, that bucket of 16 authorities, us and the 15 others, where we're in the kind of top 3. So there's much to celebrate. In terms of where we're going not so bad, the specific recommendations are probably more of a note to myself. There are 1 or 2 things around the percentage of people who are doing more than 30 minutes activity, those who choose to travel to work by walking as opposed to by car, and 1 or 2 things about diet, which you may say, well, that's a bit weird because you're just cutting particular services around diet and physical activity in the rest of the agenda. But when we've referred to a review of diet, you know, there's nothing in the service proposals that we've put forward that I would disagree with. But coming back to the point I made when Liz was here about just reviewing, are we making the most of the things that will really shift the bulk of the population on a bit, both in terms of their 5 a day and their activity? That's the kind of review overall in terms of the spend of the public health budget that I need to get right. So although I'm being independent with myself, if you like, I suppose, in terms of reviewing what we're doing. The other one, which I know Mr. Harrison takes to heart, is around PM 2.5. And again, if you look at our comparative performance, then air quality cannot be anything other than a top priority as well going forward. So I've made a few recommendations in there. We were at Health and Wellbeing Board yesterday. I made the offer to go out to any partner organisations, because rather than make specific recommendations for them, I think it's a question of them reflecting on the content of the report and then using it to generate their own recommendations and hypotheses about how they might want to respond. And I suppose the last point is, and this gets on to next year's, if this is a broad brush, given the size and scale of Leicester's population, sometimes the indicators can look a bit vanilla. We come out as about average. But of course, the important thing is then to dig into a bit more detail, which I'd like to do in next year's report, and look at how health is experienced by different groups and different communities, because there may be things underneath the overall picture that we need to consider. So so it's there on its, and I should say it's on its way to Cabinet at the end of November, and it's then considered by full council at its December council meeting. So there you go.
Well, we'll ignore and not minute the plagiarism part of the report. So,
learning from best practice. Not Rebecca Reeves, Reeves.
Mr. Muir.
Very much, Chair. Have you you haven't published this report, so hopefully any comments we could do update. The reason being is vaping. I know smoking is in there, but vaping is one of the biggest concerns I think out there amongst parents, especially with younger children, you know, around the teenage part. Vaping now rather than smoking. I think it's the more fashionable thing to do rather than have a cigarette. And I think that is going to be an evolving thing in Leicestershire and all over the country over the coming years. It would be good for us to recognise that as an issue. Maybe not a problem. Problem is probably too strong a word. An issue, along with smoking, but I think more than smoking now, because I think the concern of parents and like-minded people out there is that it will lead to other things, and what we are going to do to address that. Because putting my hat off the future on, you know, crystal ball, I can see campaigns in the future of trying to get children not to vape rather than not to smoke coming forward. Thank you.
Yeah, it's a good point. I think in Mrs. Richards' position statement, we covered vaping last time around with the smoke-free generation stuff. So as you'll know, it is not as if we aren't working on that one. How it relates to health is interesting. Again, you know, it's limited at the moment in terms of the direct health impact of vaping on children. I mean, it's not inconsequential, but it's not obviously nowhere near as bad as smoking. You got to be thinking, of course, at the moment, I don't think there is any indicator locally that would tell us what the prevalence of vaping is. So if it doesn't show on the dashboard, there's a reason, which is, again, we'll only get a measure once it's a problem, which is, it would be nice to get ahead of the curve on that one.
Mrs. Richardson. I would assure you that it's one of my things that I'm watching very carefully, and we are trying to work between the smoking cessation, where we do use vapes because it helps people get off cigarettes, but then tackling the children's issue. So yeah, we've been working with trading standards as well about it. Thank you. I do watch with concern my 2-year-old granddaughter picking up objects and vaping like her father does, and that is quite upsetting to me, because, you know, she is learning that it's something that you get gratification from, but she doesn't know what. So I'm hoping that they'll find something that can look as cool as vaping, but be completely harmless as well. So, but anything you take down in your lungs that's not oxygen related, I would imagine would be harmful to you. Thank you.
I suppose like a carrot would really do it, would it? That's cool.
No. So we do note the report and we accept it. Thank you very much, Mike. And you did very well on your own. So we note the work programme, and are there any questions from it? No. The date of the next meeting is scheduled for the 17th of January. So if I don't see you before that, have a lovely New Year and a safe Christmas. Thank you.